call Dr. Raj Kamal to present a case of acute flaccid paralysis to Professor Dr. Lima Paulin ma'am. Dr. Lima ma'am has an impressive amount of knowledge and constantly keeps updated with the advancement made in the field. Ma'am's stronghold in the medical field has brought an exceptional name for her in ICH, and ma'am can rightly be called the Sherlock Holmes of ICH. We welcome you, ma'am.
Good afternoon, everyone. At the outset, let me thank our registrar for giving us this opportunity. I know post-lunch how much it will be difficult. I myself is feeling sleepy because I had food nearly an hour earlier. Okay, so everything you know about GBS, only this is before going to the examination, just brushing whatever already you know, and if at all, if you have any doubts, to clear those doubts. So the presenter will be presenting, but the questions will be only to the audience, not to the presenter. And all of you should give a collective answer or just shout, so that the prime aim is to stay awake. That's all. Yes, please, my dear. And it will be little fast. So if you are having any difficulty to follow it, just raise your hand. Okay? We have to finish it off within 45 minutes. If possible, within 40. Yes.
Good afternoon, ma'am. First of all, good afternoon to everyone. And first of all, I am thanking Dr. Srinivasan sir for giving this opportunity. Moving on to the case. 11-year-old female child, Sweta, second born to non-consanguineous parents from Chennai, brought by her mother, whose reliability is good, with complaints of inability to move all four limbs for duration of 1 day. History
So what is your inference? Inability to move all the four limbs. Fast. Quadriplegia.
Yeah.
Inability he is telling, so quadriplegia. So we are discussing a case of quadriplegia. So think about that. How much he is going to tell us in the history of present illness. What else you are going to need? Yes.
History of presenting illness. The child was apparently normal till afternoon of March 16. Then child complained pain in the both lower limbs, which was present diffusely throughout the limbs. However, there was no difficulty in moving the limbs. Mother consoled her and child.
Pain, what could it be? Was it arthralgia? He was telling throughout the legs. So it could be a myalgia. Okay? Right. What are the causes for myalgia? Think about. Next. Proceed.
Child went to sleep. And 2 hours later, when the child woke up, she was not able to get up from the bed and she couldn't move her lower limbs. She called her parents. They made her to sit on the bed. When they made to sit, she was able to sit up without any difficulty. When parents made her to stand, she was not able to stand and she couldn't walk without support.
That means she had initially paraplegia. Okay, she was not able to move her limbs in the bed. She was not able to sit up on her own. That means she had some amount of trunk muscle weakness also. When the parents made her to sit, she was able to sit without any swaying on to either side. But when they made her to stand, she was not able to. That means definitely paraplegia is there, plus trunk muscle weakness. Okay? Yes. Was it symmetrical or asymmetrical? Symmetrical. Okay? Right. Next.
There was no history of weakness of upper limb at that moment, and she was not able to turn from side to side. And she was given milk and she drank without any regurgitation. In the evening, the child was taken.
That means she did not have any bulbar weakness at that point of time. And there was no history of weakness of the upper limbs at that point of time. Yes. Proceed.
In the evening, the child was taken to a nearby private clinic where they prescribed ORS and some oral medications and sent home. Later at night, when the child given dinner, mother noticed that she was not able to hold the tumbler, hence she was fed by the mother. She was able to swallow the food and the liquid without any regurgitation. So the upper limb is involving.
You please continue.
Please. Next day morning, when the child woke up, she had difficulty in raising the head from the pillow. No history of suggestive of cranial nerve involvement at that time.
So, over the hours, she developed upper limb involvement also in the form of difficulty in holding. So, distal weakness. Okay, we have not asked for the difficulty, whether she had difficulty in raising the limb above the shoulder, to say whether she had proximal weakness also. The next day morning, she had difficulty in lifting her head off the ground or off the pillow. So she had neck muscle weakness also. Okay. So what does it mean? It is
Progressive,
ascending. So it is a symmetrical weakness initiated beginning from the lower limbs, trunk muscles, then upper limb, then neck muscles. So it is an ascending paralysis. Yes, proceed.
Then child was brought to the ICH for the above complaints. At the time of at the time in the ICH, child had weakness of all four limbs, lower limb more than involvement of upper limb with the trunk and neck muscle weakness. No history of stiffness or flainness of limbs. No history of fluctuation of weakness or diurnal variation of weakness. Child was able to perceive bladder sensation. However, there was difficulty in initiation of micturition. No history of sensory disturbances or blunting of sensations. No history of blurring of vision. No history of abnormal position of eyeball. No history of deviation of angle of mouth. No history of difficulty in closing the eyelid. No history of reduction in voice volume. No history of nasal regurgitation of foods. No history of difficulty in turning head side to side. No history of difficulty in protruding the tongue. No history suggestive of higher mental function involvement such as altered sensorium or behavioral disturbances. No history of fever either at the onset or prior to the...
Wait. So always the history of present illness consists of two parts. Okay. Number one is to find out the extent of the illness or to find out which part of the neuraxis is involved. Then the second part considers the etiological causes. Okay. So from the first part of the presenting illness, we have to find out, there are only 3 questions in neurology you are well aware of. Is there a neurological problem? Yes or no?
Yes.
Yes. Okay. Why do you say so? Could it be a pseudoparalysis? Child is malingering or due to pain. Now what is pseudoparalysis? Fast.
Due to the pain, due to the exhaustive pain.
No answers from you, my dear. Yes, chorus answers. What is pseudoparalysis? What is a true paralysis? True paralysis is whenever there is some difficulty in moving the limbs or weakness. It should be associated with weakness. Then only you can call it as a true paralysis. Suppose there is a difficulty in moving the limbs or inability or difficulty in using the limbs due to pain or restriction of movements, then you call it as a pseudoparalysis. What are the causes for pseudoparalysis? Chorus answer. How many scurvies you have seen, my dear? Yesterday we nicely saw the X-ray shown by our radiologist. Have you ever seen a scurvy, infantile scurvy?
No.
We ourselves have not seen. Okay? Yes. Yes, common things you say first. Fracture, sprain, then cellulitis.
Osteomyelitis. Rheumatic
toxic synovitis.
Rheumatic fever.
Septic arthritis.
Rheumatic fever.
Then
Rheumatic
what?
fever.
Okay, then hematoma. See, some hematoma is there. Let it be due to trauma or due to your this one coagulopathies. You have a hematoma, hemarthrosis. Then what? Inguinal adenitis. Okay, injection abscess, gluteal abscess, some abscess, cellulitis. Then what? Psoas abscess, appendicitis. Because of all these things, if at all these are due to local inflammatory pathology. So if due to any pain there is a restriction of movements, then you call it as a pseudoparalysis. There is no true paralysis, there is no true weakness of the limbs. And all your reflexes will be normal. Neurological examination will be normal. The child is not able to use the limb, or that gait is called an antalgic gait or a painful gait, which is due to painful restriction of the movements. Okay? These are all the things which are clubbed together under pseudoparalysis. Apart from this, of course, you have 2 more conditions in infancy, namely congenital syphilis and infantile scurvy, in which there will be these things we do not see often, but our senior pediatricians would have seen so many cases, so they would have been very much interested in asking these questions. That's why we are telling you. So infants, say 3 months, 2.5 months, 3 months, if somebody is bringing their small kid with the child is not at all moving the limb, then you have to ask one particular question. What is that, my dear? Very good. Where there is pain on handling. Okay. So if you leave the child just like that on the ground or on the table, child will be nicely lying down. When you lift the child will be crying with pain and irritable. That is pain on handling, or the child will be comfortable while lying down, and when the child is not lifted up. Okay, in congenital syphilis, this irritability is due to periosteitis. Periosteitis. Then in infantile scurvy, it is due to
Periosteal hemorrhage.
very good, subperiosteal hemorrhages. Okay, so these are the conditions you should think about, what is called under the rubric pseudo paralysis. So whenever somebody is telling my child has difficulty in walking, or difficulty in lifting, or difficulty in using one limb or both the limbs, then you have to think about this as a first step to rule out those things. Okay, right. So that is step number 1. And then when you have ascertained yourself or satisfied yourself that it is a paralysis only, it is a neurological problem only, then we have to find out whether it is an upper motor or a lower motor neuron, and under lower motor neuron, where is the level of the lesion. For that only we have to ask so many questions. For that only he has asked these questions. Okay, whether there was a history of stiffness or flailness of limbs. And earlier part of the history told you about the extent of the illness. What is the extent of the illness for this child? Is it a quadriplegia or not? Yes. Whether the cranial nerves are involved or not? History wise, whether you told any history of difficulty in swallowing, nasal regurg, reduction in voice volume, anything else? No. One more history what he should have told you is whether there was any history of respiratory difficulty or respiratory distress or breathlessness. That is important. Okay, that will tell you whether the respiratory muscles or your intercostals are involved, or whether your diaphragm is involved. Okay, so from the history you have information that the child had a quadriplegia. It was bilateral, symmetrical, ascending, initially lower limbs. Initially it was in the lower limbs, it is proximal, because the child had difficulty in getting up from the squatting position. So proximal, then in the upper limbs, trunk muscle weakness, then upper limbs distal. Okay, that much you know. Now you have to find out whether this is a UMN lesion or a LMN lesion. What are the features of UMN lesion? Spasticity. Chorus, fast. Exaggerated reflexes.
Plantar
extensor. Abdominal is absent. What else? Clonus. Pyramidal signs. Okay. What about the weakness? So your homework today is what is called pyramidal weakness. You read. Okay.
Anti-gravity muscles are
anti-gravity muscles. So tone is increased in the anti-gravity muscles. So spasticity will be more in the anti-gravity muscles. So what about the weakness? Is the individual muscles are weaker in a human? No. Groups of muscles, or it is the movement, that particular movement. Usually it is the distal movements are more involved. Okay, so that is human lesion. Whereas when we are having in this particular child, you know pretty well there is a condition called spinal shock. During the acute period, even in a human lesion, the children will be behaving or will be exhibiting the LMN signs. That is called spinal shock. What is the duration of spinal shock?
It can vary, ma'am, 24 hours to 7 days, maximum 7.
Usually it is 2 to 3 weeks, even up to 3 weeks you can have. Initially it was described only in traumatic myelopathy, but afterwards, later it has been described in all other conditions also. Okay, so whether this is particular child is having a myelopathy or a transverse myelitis, who is in the period of spinal shock or not, we have to find out. Okay, that's why he is asking stiffness or flailness. Of course, during the period of spinal shock, it will be flailness only. There are some other clues that we will come. So stiffness or flailness, for that only he has asked. Then what else he has told you? There was no diurnal variation, or there was not a fluctuating. Within 24 hours, it would be difficult to find out diurnal variation and all. But fluctuating weakness to little extent we can say. And it was not a fluctuating. Why he has asked that? Whether it is a neuromuscular junction problem or not. What else he has told? Fast. Next line. What else you told us? Sensory disturbances. Why do you need the sensory disturbances in this particular child? Yeah, whether with the presence of a sensory level or a sensory blunting or below a line or a below a level, the child is not able to perceive any modality of sensation, then it is then it is cord involvement or myelitis rather than it is a radiculopathy. So for that you need to ask this question. What else you have asked? Bladder disturbances. Okay, early bladder point towards a cord lesion rather than LMN. And the other, what else you have told? You can ask for even sweating disturbances also. In transverse myelitis, there is a level or below that level, everything is lost. Motor, sensory, autonomic, everything will be there. So you can ask sweating disturbances also. Whether the child is sweating above that level and below that level, there is no sweating. You can ask that. So from these things, you can fairly, and he has told you about the whether there is involvement of cranial nerves or not. Okay. So from this, you can find out to some extent what it is. Whether it is a human or element, and if at all, if it is an element, where could be the lesion. Okay. Right. Next. So what are the constituents of element? What are the parts that come under elements? Anterior console,
Nerve root,
or radical,
nerve,
plexus, but we don't have in pediatrics, we have only brachial plexus injury. Apart from that, we do not read anything else about the plexus. So you can forget about the plexus.
nerve root, nerve,
Nerve, peripheral nerve,
neuromuscular junction, then muscle.
and muscle. So all if you say it is an element, then where do you want to place the lesion also, you have to think about at this stage. Okay. So where and all can present. Now this is a weakness or quadriplegia. So do you think it could be a human also in the period in the phase of spinal shock? Number one. Number two, what else could be there? Could it be anterior console lesion? The only acute anterior console involvement you know of is poliomyelitis. Could it be a poliomyelitis?
Fever at the onset is not there.
We have not come to that level. Could it be a poliomyelitis? Etiological history we have not yet asked.
Yes.
Whether the polio can present you as this like quadriplegia?
No, ma'am. It will present.
What are the different forms of poliomyelitis?
Inapparent infection,
abortive polio,
non-paralytic poliomyelitis, paralytic poliomyelitis.
Among the paralytic,
bulbar,
number one spinal, then bulbospinal, bulbar, cranial. So spinal is the commonest form among the four. That one inapparent, abortive, non-paralytic, paralytic. Paralytic, most of the infections is usually an inapparent infection. Then comes abortive, then comes non-paralytic, then comes paralytic. So paralytic polio is, considering all these four forms, it is rare. And under paralytic polio, the spinal form is the common one. Spinal polio is just unilateral, only one limb involvement. One limb involvement. Usually the lower limb. Lower limbs are more involved than the upper limbs. Proximal more than the distal, like that. Okay. So if only one limb is involved, then you can think about the polio also. But here you have four limbs involvement. Okay. So polio will not come under your differential diagnosis. It could it be a non-polio enteroviral infection? Can be. Okay. Then comes radical. What are the causes for radicalopathy?
Guillain-Barré syndrome.
Guillain-Barré syndrome.
CMV radicalopathy.
CMV radicalopathy and all only in immunocompromised, dear. Suppose you have a child with a retroviral illness and now presenting to you with a radicalopathy, you can't think about CMV radicalopathy. Anything else? Radical, fast. Post-diphtheritic palsy, tick bite paralysis. What
Lyme's
else?
disease.
Lyme's disease, yes.
And
Anything else?
porphyria.
Acute intermittent porphyria. Radical and nerve you can consider together. Okay. Some insecticide or organophosphorus poisoning. So many these things you have to consider under the radical.
Drugs.
Drugs. Okay. Then comes your neuromuscular junction. What are the causes for neuromuscular junction problem which can present to you as like this, quadriparalysis or quadriplegia?
Myasthenia gravis.
Myasthenia gravis.
Snake bite envenomation.
Yes, neuroenvenomation.
Then botulism.
Botulism. Okay. We will consider each these things in the discussion. Okay. So these are the things that should run in your mind whenever you have a child like this. Then muscle.
Hypokalemic periodic paralysis.
Whether it is a periodic paralysis,
dermatomyositis,
polymyositis or a viral myositis. Okay. So all these conditions can present to you as an acute onset of weakness of limbs. Okay, yeah. Then comes your etiological history. So considering all these things, we have to ask certain questions to rule out one by one. Now begin.
No history of fever either at the onset or prior to the onset of illness.
Either at the onset of the illnesses?
Polio.
2 to 3 weeks prior to the onset of the illnesses?
Guillain-Barré syndrome.
Guillain-Barré syndrome. Next.
No history of loose stools or cough and cold 2 to 3 weeks prior to the onset
For
of
what?
illness. For the etiological
Again,
cause
for
of
Guillain-Barré syndrome.
syndrome.
Guillain-Barré syndrome can have, there can be a fever or URI, something like that, 2 to 3 weeks prior to the onset of the illness. Suppose there is a diarrhea, it could be a Campylobacter jejuni diarrhea, so the child can have an GBS, of course, axonal form. Yes, next.
No history of recent exanthem or vaccination.
Again, post-vaccinal demyelination or a post-exanthematous demyelination, okay? What are the vaccines that can cause such a post-exanthematous demyelination?
Influenza vaccine.
Influenza vaccine.
Rabies vaccine.
Rabies vaccine. Nowadays, don't say rabies vaccine because previously we used to give simple vaccine. Nowadays, it is all recombinant vaccines or what is that? Vero cell vaccine. So, for that and all, you do not develop Guillain-Barré syndrome. So, leave away that rabies vaccine. Number 1 is influenza vaccine, accepted H1N1 vaccine, then that is swine flu vaccine.
Meningococcal vaccine.
Okay.
TD
then,
vaccine.
TD vaccine. Okay. Next question.
No history of headache, vomiting, seizures or altered sensorium.
Why you have asked this question?
Any acute meningitis or Adam can
Whether the child is having associated encephalopathy or not. Suppose there is an higher function involvement or suppose the child is having altered sensorium presenting with a quadriparalysis or a quadriplegia. What could be the possibilities?
Adam, acute meningitis.
Adam, it could be a acute disseminated encephalomyelitis, number 1.
Acute meningitis with meningitis.
Adam accepted. Anything else? Any other polyradiculopathy, radiculopathy which can present with encephalopathy? You have
Because
told
of
us
brainstem encephalitis.
that is again it will come under okay meningoencephalitis, then that and all is very high for you. You need not think about all those things. Anything which we have enumerated so far can present to you with along with this polyradiculopathy with encephalopathy.
Poliomyelitis, meningoencephalitis along with
Porphyria, my dear, acute intermittent porphyria, that can present to you with encephalopathy. Okay, next question.
No history of trauma.
No history of trauma. Trauma is only for whether there is a traumatic dislocation or traumatic hematoma or hemorrhage inside the spinal cord. Next.
No history of back pain.
Back pain. What for? What for? Suppose there is a localized pain. There is a pain in the spinal tenderness and there is a localized pain in the back. That can tell you that it could be a cord compression, extradural cord compression, compressive myelopathy. What is called girdle pain? Fast. Don't sleep. What is girdle pain? It is a, yes please. Bilateral dermatomal pain, as if you are tightening your waist with a belt. It will be such binding pain. So that if there is a history of girdle pain, that denotes that the particular child is having an ATM, that is acute transverse myelitis. Okay. For that purpose, you have to ask this question, history of back pain. Apart from the compressive myelopathy, which could have been due to any extradural cord compression, even pot spine. But those things will not present to you as an acute weakness. Okay. For that only, if at all, if there is a girdle pain, then it is equivalent to ATM, acute transverse myelitis. Next.
No history of abdominal pain.
What for?
Lead poisoning and porphyria.
Very good. Again, any polyradiculopathy plus abdominal pain, acute intermittent porphyria. First diagnosis. Next.
No history of ingestion of honey or canned food substances.
What for?
For botulism.
Botulism. Okay. Adulterated honey or contaminated honey plus canned foods. Botulism. For that only you are asking this question. Good. Next.
No history of dog bite or sting.
What for? Dog bite. What for? Fast. Rabies. Whatever you see commonly is your furious rabies, in which the child will be very anxious and then child will be having hydrophobia, aerophobia, child will be conscious throughout, suddenly child is developing a respiratory paralysis and die. That is the usual rabies which you happen to see regularly. But there is something else called, in nearly 15 to 20% of the children who had a rabid dog bite, they can develop something called paralytic form, in which it will be exactly clinically mimicking or similar to your Guillain-Barré syndrome. Bilateral, symmetrical, ascending paralysis, initially lower limb, trunk muscle, upper limbs, like that. So for distinguishing that only, you have to ask this question, namely history of dog bite. Clinically, you will not be able to distinguish at all, unless otherwise you have a history of dog bite And whether it is a class 3 bite, you have to ask whether the child has received both immunoglobulin as well as vaccine. You have to ask. The other clues will be in that site of bite there will be paresthesia. Okay, if you do an MRI there will be a cord involvement. These are the clues. But if you have any doubt, you have to proceed with IVIG only. Okay, what is how will you diagnose rabies antemortem? Corneal smear and
Corneal smear
absolute,
is not recommended.
it will tell you, it may be false positive or false negative. So don't say corneal smear.
Brain by
Either skin from the scraping of the neck looking for negri bodies, or else
brain biopsy.
the best thing will be
Biopsy.
antemortem. I am asking, my dear. Antemortem. CSF for RT-PCR for rabies antibodies. RT-PCR. Okay, for neutralizing antibodies. So that is the confirmatory test for diagnosing rabies antemortem. So if you suspect, if there is a history of dog bite in a child presenting to you with like this, then do CSF. Of course, you have to take all precautions against rabies. You have to wear double glove. And then send a sample for RT-PCR for rabies. Okay, right, next. And then any sting or bite he is asking, what for? Any snake bite. Okay. The two common types of snakes you have are, one is vasculotoxic, another one is neurotoxic. What will be the presentation of a neuroenvenomation?
Ptosis.
Good. So presence of cranial musculature involvement. Ptosis,
Ophthalmoplegia.
ophthalmoparalysis or ophthalmoplegia,
Then
facial weakness, bulbar weakness, respiratory paralysis. Then only generalized weakness. So initially there will be ptosis, ophthalmoparalysis. Okay. For that matter, any acute onset of ophthalmo-facio bulbar weakness and with any cellulitis in any part of the body, even though there is no fang marks, until proved otherwise, you have to consider snake envenomation and you have to proceed with ASV. Whether in neuroenvenomation your whole blood clotting time will be normal or prolonged? Normal. So don't say whole blood clotting time was normal. Yes, it will be normal only. But when you have such a history, you have to ask some more histories. Whether the child got up in the middle of the night and cried and then slept away, and when the mother woke up the child, that at that time itself there was whether she noticed ptosis, whether the child had bulbar involvement, whether the child had respiratory involvement, like that you have to ask. Okay, that is number one. Other clue will be pupils will be equal reacting to light in this case. So in neuroenvenomation, it is only a neuromuscular junction problem. It is nothing to do with your pupillary fibers. So pupils will be normal. Number two, if there is a severe weakness, they can have areflexia. So with that we cannot. So only clue will be such a history and presence of this ptosis, initial ptosis, ophthalmoparalysis, facial, bulbar, respiratory, along with the generalized weakness. In such a scenario, you think about snake bite. Okay? So for that only you have to ask all these questions. Anything else, my dear?
No, ma'am.
Do you want anything to be added? Anything else you want? So this will complete the history of present illness in a given child with an acute flaccid paralysis. Okay? Right. Any doubts? Proceed, my dear.
Past history, no history of throat pain or swelling in the back 2 to 3 weeks prior to the onset of illness. No history of similar episodes of weakness or no history of any drug intake.
Why are you asking this question? This is a very important question. You should never miss that question in your case sheet. History of similar episodes before. Number one.
Periodic paralysis.
Periodic paralysis. Unless otherwise you ask this question, you will miss the diagnosis of periodic paralysis. Okay? Next.
Ma'am, GBS relapse.
Very rarely GBS can recur. Very rare. Don't say as the first cause. Okay? Every year we tend to have nearly 30 to 40 cases of GBS in this hospital. I have seen only 2 cases of recurrent GBS in this 21 years. Okay? So don't say this as a first possibility. Think about hypokalemic periodic paralysis. That is the number one thing you have to utter whenever you are asked this question. Why did you ask this question? Hypokalemic periodic paralysis. That will be your answer. Next.
Okay. No history of any drug intake.
Okay.
Antenatal history. uneven full
Skip
natal
everything and go for general examination. All those things are
course in
maybe
the hospital.
all these things will be important for you people. Yes, course in the hospital.
After the child was admitted on day 1 of
And
the
another one you have to consider is whether the child is having any underlying medical illness. Sometimes the child would have been receiving this lymphoma or leukemia, ALL. These children can develop radicular neuropathy. Maybe drug induced, maybe part of the disease itself. Similarly, uremia, CKD children, uremic polyneuropathy is known. So any medical illness the child is having also you have to mention.
course in the hospital. After the child was admitted on day 1 of admission in the evening, the child also developed difficulty in swallowing the food, nasal regurgitation and a reduction in the voice volume. Over the next 2 hours, child developed breathlessness. For that, child was intubated and mechanically ventilated. Summary: a 11-year-old female child, second born to non-consanguineous parents with acute onset of weakness of all 4 limbs, symmetrical initially in the lower limbs which progress to involve the trunk, upper limb and cranial nerves and respiratory muscles, requiring ventilatory support without involvement of higher mental functions and sensory system. Acute onset of ascending paralysis, a case of acute flaccid paralysis, most probably a case of Guillain-Barré syndrome.
So we have only 15 minutes. So at this point of time, what is your diagnosis with the history alone? Fast, 2 minutes. He has not told us about the flaccidity. He said there was no history of illness or stiffness of limbs. However, it was an acute weakness. Define AFP.
It's a acute onset of weakness less than 4 weeks in less than 15 years of age or in any age when polio is suspected.
Less than 4 weeks and all is not in the definition, okay? Any acute onset of weakness of any part of the body in a child less than 15 years or in any age in whom polio is suspected. So previously they said flaccid. Now they have taken away that word. So is it a AFP? Yes. Here is an acute weakness of limbs. Whether this child is less than 15 years? Yes. It is an AFP. Okay. So what are the causes for AFP?
From the level of the lesion.
So far we have enumerated so many things according to the level of the lesion. The another approach is whether it is unilateral or bilateral. Whether it is unilateral or bilateral?
Bilateral.
Bilateral. You as a pediatrician you have to remember only 4 things. All those things you have to of course remember and evaluate the child. And 4 things are most important. What are those things?
Guillain-Barré syndrome.
Number 1, acute poliomyelitis. Number 2, Guillain-Barré syndrome. Number 3, acute transverse myelitis. Number 4, traumatic neuritis. It's very easy to categorize like this: unilateral or bilateral. Unilateral, poliomyelitis, bar, traumatic neuritis. Only 2 conditions. Bilateral, Guillain-Barré syndrome or acute transverse myelitis. That's all. Whether this is unilateral or bilateral, it's a bilateral. So it is you need to distinguish only 2 things, whether it is a Guillain-Barré syndrome or acute transverse myelitis. That's all. Okay, fine. Go to the general examination. Anything important?
No, ma'am. Child conscious.
Whether the child is conscious or not,
yes,
we need to know. Because encephalopathic or whether the child is in altered sensorium, we need to know, number 1. Anything else?
No, ma'am.
No. Next.
Vitals stable, ma'am. All vitals are stable
so
at the
you
time
need
of
to
admission.
examine when you are receiving the child. It is very much essential that you look at the ABC. Okay, right. Going to the central nervous system examination. Higher mental functions.
Child conscious.
Normal.
Yes, ma'am.
Normal. Cranial nerves.
Initially, there was no cranial nerves except for in the evening, the child developed pooling of secretions and reduction in the volume and by 9th and 10th gag reflexes.
What are the cranial nerves you will consider or concentrate in a child with the AFP?
Bilateral facial nerve paralysis.
Number one, go by the order. Now, second nerve, optic nerve.
Yes,
you have to ask for whether there is a blurring of vision, whether the visual acuity is normal or not. What for? Child may be a case of NMO, that is your Devick's disease, neuromyelitis optica, in which the child is having a transverse myelitis, having a quadriplegia. In addition, child is having optic neuritis also. That's why second nerve. Number 2,
3, 4, 6.
4th, 6th cranial nerves. Good. What for? Ophthalmoparasis you have to look for.
For myasthenia gravis.
There is an ophthalmoparasis. What could be the possibilities?
For myasthenia gravis, snake envenomation, botulism.
Second one, what did he say?
Snake envenomation.
Snake envenomation, botulism. You are thinking about a neuromuscular junction problem. Anything else? Miller-Fisher variant. Okay, Miller-Fisher variant. So that should be your first answer. Then say about the neuromuscular junction problem also. Next, bilateral facial. How will you ask for a bilateral facial weakness? Don't ask for is there any deviation of the angle of the mouth. Will a child will have deviation of the angle of the mouth when the child has a bilateral weakness? No. So you have to ask a mother whether the child sleeps with his eyes or her or his eyes closed during night. or whenever the child sleeps. Only half open irukna, then it means there is a bilateral facial weakness. Some mothers will be telling all the throughout my child will be liking sleeping like this only. Then it becomes difficult for you. Okay? Then you have to ask for bulbar weakness. What and all you will ask for bulbar weakness? Whether there is a history of difficulty in swallowing solids, liquids, whether there is a history of nasal regurgitation to liquids, whether there is a reduction in voice volume. அழுவும்போது பேசும்போது குரல் கம்மியாக இருக்கா, இதுக்கு முன்னாடி நல்லா சத்தமாக பேசும் இப்போ கம்மியாக பேசுதா, குரல் கம்மியாக இருக்கா, that's what you have to ask. Okay? Then examinationல
gag reflex,
what and all you have to look for?
palatal and pharyngeal
Palatal
reflex,
movements are normal or not,
uvula
whether
inhibition,
the uvula is deviated or not, then whether there is any pooling of secretions. Pooling of secretions. Normally you don't expect a uvula deviation, it is a bilateral weakness, so you don't expect a deviation of the uvula and all. Whether the palatal movements are diminished, pharyngeal movements are diminished, then whether there is any pooling of secretions, that's what you have to examine. And whenever you are intubating the child, think and check whether the child is coughing or retching or gagging or not. Okay? You are intubating, the child is not at all having a cough reflex, then it means that there is a bulbar palsy. Okay? Right, next. So these are the cranial nerves you are going to concentrate in a child with acute flaccid paralysis. Next.
Examination of motor system, bulk and nutrition are normal. There is a hypotonia in all four limbs, and power, shoulder
you expect hypotonia only in this particular child, so that doesn't give you any more information. Next. Power,
shoulder flexion, extension, abduction, adduction, power 1/5.
All movements in all groups of muscle in all the four limbs, it is 1/5 only. Next.
Elbow,
so that must be trunk muscle weakness, there must be neck muscle weakness also. Next.
Elbow flexion, and both flexion and extension.
Leave it. Next. All are 1/5. Next.
In lower limb also it was 1/5, ma'am.
Okay.
It is symmetrical.
Okay.
And examination of neck muscles weak, examination of trunk muscles are also weak. Coordination could not be tested and no involuntary movements.
Next.
Superficial reflexes, corneal reflex, conjunctival reflex present on both sides. Initially there was palatal pharyngeal reflex present on both sides. Abdominal reflex is absent, plantar no response.
So in GBS, in radiculopathy, you don't say plantar absent and all. You have to say plantar no response. Okay? Right, next.
There
deep
was
tendon reflexes.
Even with the Gendrasic maneuver, the deep tendon reflexes are absent.
Absent, okay. Next.
Sensory system able to perceive touch, pain and temperature on all over the body. No sensory level. Joint sense, position sense and vibration sense perceived normally on both sides.
Okay, next.
Examination of cerebellar system, no nystagmus, coordination such as
could not be tested. If the power is more than 3 only, you can check for coordination. Otherwise, no, could not be tested. Next.
Coordination could not be tested and other cerebellar signs could not be tested. Gait could not be tested. No meningeal signs, spine and cranium normal.
Rhombox also could not be tested. Next, spine and cranium. Were there any meningeal signs?
No, ma'am, no meningeal signs.
Children, suppose the meningeal signs are present. What are the possibilities?
Poliomyelitis.
Poliomyelitis, you can have positive meningeal signs in poliomyelitis. Number 2, even in GBS you can have. Okay? So, next.
Examination of other systems.
Essentially normal. What else he has missed? Spine he has told you, spinal tenderness you have to look for. Next. You have to palpate the bladder. Autonomic involvement is also there or not. You have to, in the vital signs also you have told. But in addition, you can repeat that and you have to palpate the bladder. You have to percuss for the bladder. Okay? Whether there is any bladder distension is there or not, you have to look for. Okay? Now, after examination, what summarize? Don't say the history. Only summarize the clinical findings.
Acute onset of quadriplegia, progressive with a bulbar and respiratory failure. On examination, conscious child, flaccid quadriplegia, bulbar palsy, respiratory paralysis, no sensory involvement.
So good. A conscious child with a flaccid, madam, good afternoon. With a flaccid quadriplegia with a neck muscle weakness and bilateral facial was there?
No, ma'am. Only
so
bulbar
only
palsy.
With the bulbar palsy. Okay. So now you come to a conclusion what it is?
Is
it upper motor neuron lesion, whether this is a transverse myelitis?
No.
No. Why do you say no?
There is no sensory level.
There is no sensory level. Very good. Whether there is a bladder involvement? No.
Yes.
Okay. Bladder is involved?
Distended bladder is there, ma'am.
Distended bladder is there. Okay. So bladder is there. And in GBS, whether the bladder can be involved or not?
Can be a transient, ma'am.
15 to 20% of the individuals, the bladder is involved for the first few days only. It is a transient bladder involvement. Okay. When will you think about whether it could be an acute transverse myelitis in this in a given scenario? Whenever there is an asymmetrical onset, one limb involved, then other limb, next day or next one or after 1 or 2 days, the other limb, other lower limb is also involved. Suppose there is such a asymmetrical presentation. Number 2, early bladder. Early bladder. Somebody says acute retention of urine. You need to catheterize to relieve the bladder. Then you have to think about cord. Number 3, persistent bladder involvement. Presence of a sensory level. Plant are going upgoing. In such a situation, think about whether it could be a spinal cord. Okay? Then, is it Guillain-Barré syndrome or not?
Yes, ma'am.
Yes. So, you have ruled out other things. Is it not? Is it a muscle? No.
No.
Next, is it a neuromuscular junction?
No.
No. Because there are the ophthalmoparasis, so ocular muscles are not at all involved. There is no ptosis. So many things are not there. Okay? Then, whether it is an anteroconsal involvement, we have discussed whether it is a poliomyelitis or not. So, we are left out with only a radiculopathy. Among this radiculopathy, polyradiculopathy, the commonest cause is Guillain-Barré syndrome. So, you have clinical criteria for Guillain-Barré syndrome. You check whether this case fits in with the criteria of a Guillain-Barré syndrome. What are the conditions or criteria for a Guillain-Barré syndrome? Clinical criteria?
Modified Asbury criteria.
Yes, fast.
Yeah, the criteria essential or needed or progressive weakness of 2 or more limbs in any part of.
Is it there in this particular child?
Yes,
progressive weakness of more than one limb? Yes. Next.
Areflexia.
Areflexia, whether it is there or not. So, compulsory things, necessarily present things, mandatory things are present in this particular child. Okay? What are the points that can that should be present or that can add on to your diagnosis?
Absence of fever at the onset.
Absence of fever at the onset.
There is a mild sensory symptoms. Bilaterally symmetrical weakness.
Symmetrical weakness. Very good.
And there is
absence of sensory level. Okay. So, these points are favoring a diagnosis of polyradiculopathy and Guillain-Barré syndrome. Now, tell me, how will you investigate this particular case?
For serum, for to ruling out periodic paralysis, serum electrolytes.
Whenever you receive the child, can you send the child home? Somebody is coming with an acute flaccid
I will
paralysis.
admit the child.
No. Number 1 is hospitalization. Then number 2, ABC should be looked for, and you should look for, and you have to take care about the ABC. Number 3, fast.
Investigations.
Investigation. What and all will you do? Tell me.
Serum CPK and serum electrolytes.
Before that, serum electrolytes is a must. What for?
Periodic paralysis.
If it is a hypokalemic paralysis, okay, hypokalemia is there or not? If there is a hypokalemia, if you supplement the potassium, the child will be up and about and it will become normal within few hours. So, you shouldn't miss a case of hypokalemia or dyselectrolytemia in a child with an AFP. What are the other electrolyte disturbances which can cause a acute flaccid weakness? Only hypokalemia, even hyperkalemia also can cause a periodic paralysis. Anything else? Magnesium, hypo or hypera? Hyper. That's why you are checking your ankle reflexes whenever you are giving max self drip for a patient with an eclampsia. Okay? So, think about that and remember hypermagnesemia also can cause a acute flaccid paralysis. Okay? Next investigation, fast.
Serum CPK.
So, if the clinical picture is very typical, very classical, it is a Guillain-Barré syndrome only, you have ruled out all the other things by clinical exam as well as by your history. Then do you need imaging? No. Okay? No. If you have a doubt, I have told you what are the points when you have to think about, what are the atypical points when you think about cord rather than a radical. In such circumstances, go for MRI spinal cord. Otherwise, not needed. If somebody is asking, what will be if you do an MRI, what will be the picture in the MRI?
There is contrast enhancement of the cauda icona and the nerve roots.
So, you have to, for that you need not diagnose it with a plane, you have to give contrast, GADA contrast. There can be contrast enhancement of the cauda equina. Okay? Next.
Then nerve conduction velocity study.
Yes, the thing which is going to help you in your diagnosis is your nerve conduction studies. So, you can to some extent say yes, it is a radical only, and then to classify whether it is a demyelinating type or axonal type. Based on that, your prognosis differs. So, nerve conduction is an important study or investigation you have to carry out in a child with Guillain-Barré syndrome. Next.
Then CSF analysis in the second
analysis in which you have to look for cytoalbumino dissociation. Okay, so these are the investigations you have to carry out in a child with AFP. What are the other things, considering all the other differential diagnosis?
Ma'am,
You have said CPK is elevated. If CPK is elevated, you will be thinking myositis either viral or autoimmune. Next. Anything else?
Ma'am, AFP surveillance stool samples have to be
Very
sent.
good, very good. As a pediatrician, you should never miss this point. Always stools for polio, illana AFP surveillance is a must. Okay, what is the background rate of AFP?
It should be more than or equal to 1 in 1 lakh.
1 lakh. Finish the line. Of the population, less than 15 years of age.
Less than 15 years of
less
age.
than 15 years. So that is the background rate. So the polio surveillance should be, or the AFP surveillance should be minimum 1 in 1 lakh. Okay, right. So that is a much more important thing which you should never forget. Coming to the any other thing. Suppose if you are thinking in terms of acute intermittent porphyria, when will you consider acute intermittent porphyria in a given child with a polyradiculopathy? We have told so many things. When there is an encephalopathy, abdominal pain and severe autonomic involvement. GBS itself can have an autonomic imbalance, but suppose if it is a persistent one and you have a persistent shock, you are not able to manage the shock at all. Think about AIP. So what will you do for that? What investigation? Fast.
Urine
porphobilinogen and delta aminolevulinic acid. What will be the management? What's the management? Give IV dextrose, find out the offending drug, stop the drug, give you IV dextrose, child will sit up. Okay? So these things we should never forget. We should never miss. Now coming to GBS proper, management.
Initial stabilization of patient and watching for respiratory paralysis and immunotherapy.
So always whenever you are admitting a you are admitting a acute flaccid paralysis, write down in the case sheet, look for the ABC, vitals monitoring, watch for respiratory paralysis and autonomic involvement, stools for polio, etc. and
immunotherapy.
See, it consists of general management and specific management. Now tell me about the general management. Both are equally important. Yes, you are giving IVIG and leaving aside everything else, it is not proper. So general management, first of all, you tell me.
Supportment of pain care.
ABC accepted. You should watch for respiratory paralysis. What are the signs of impending respiratory paralysis?
Bilateral facial weakness, bulbar paralysis, shoulder abduction defective.
Yes, shoulder, when the shoulder abduction is defective, shoulder abduction is C5. Okay, how long will it going to take for the C4 and C3 to get involved so that you will have a diaphragmatic weakness landing up in a respiratory paralysis? So whenever the shoulder abductors are weak, be careful, monitor the child closely, watch the child for respiratory paralysis. Anything else?
Single breath count, ma'am.
Yes, whenever there is a decreasing single breath count. For adults there is a standard, whereas for children we don't have any standards for the single SBC. So at the time of admission, monitor the or take the single breath count, and every day you go on checking. If it is decreasing, then it is an impending sign of respiratory failure. Okay, so watch for respiratory paralysis. Then autonomic involvement. What are all the autonomic signs or imbalance that can occur in GBS?
Hypertension, tachycardia.
Child can have hypertension, labile BP, tachyarrhythmia, bradyarrhythmia. So you have to manage all these things. If there is a hypotension, what will you do? It has to be managed with just fluid boluses. Prasas are not required. Okay, if there is a hypertension, again it is a labile hypertension only. Then you have to give only short acting antihypertensives, not like DOPA, TDS and all, you can just like that write and go home. No, every time you have to check and then only you have to treat, because it is a labile one. Next, what else?
Management of nutrition.
Wait, before that, and suctioning is also very important. Because of autonomic imbalance, these children can go for vagal induced bradyarrhythmias, bradycardia. So careful suctioning. Next, you were telling some points, say, in the general management.
Management of pain, management of nutrition.
Pain management by giving analgesics. Next,
management of nutrition.
Nutritional care is very, very important. Either give start feeding by your NG tube. Suppose the child is having a gastroparesis or an ileus, you can go for even parenteral nutrition. Good.
Management of fluid and electrolytes.
Okay.
To that physiotherapy, both chest physiotherapy and
chest physiotherapy as well as bedside physiotherapy has to be initiated. In many other condition, you will be doing physiotherapy not in the acute period. You will be doing once the acute period is over only. But GBS is one condition, you have to start physiotherapy on day one itself. So bedside physiotherapy has to be initiated to prevent contractures as well as to preserve the range of motion. Next.
To watch for deep vein thrombosis and
Yes. Suppose the child is a obese child and older child, because all the time the child is lying down. So you have to take precautions for DVT also. DVT prophylaxis has to be thought about. Next.
psychological counseling to the child.
Very good. And there, before that there should be some mode of or some means of communication, because all the child is remember, this child is a conscious child. Now not able to even move an inch of the body, but knowing and with so many tubes. And whereas the other children are in a state of altered sensorium. So there must be some modes of communication like letterboard or some suppose upper limb is working, some calling bell, just with that calling bell the child can call you like that. Okay. And then last but not the least is psychological counseling, both for the child as well as for the parent. You have to mention or you have to tell the parents that it is an initially the course of the illness, you have to inform them on day one itself. Otherwise they will be telling my child was walking when I admitted the child and child became paralytic like that. So it will be increasing only, or there will be a progression initially, then the child will enter a plateau. That plateau may be there for 7 to 10 days, then only child will improve. That has to be told to the parent on day one itself. Okay. So psychological support to the parent is very, very important. So all these points should be told in the general management. Now coming to specific.
Immunotherapy.
Yes.
Both immunoglobulin and plasmapheresis have same
are both equally efficacious. Okay.
Immunoglobulin 400 mg per kg.
Those and all you know, because of the ease of administration, because of the fewer side effect profile, we are preferring IVIG immunoglobulin over plasmapheresis in children. Okay. Right. Plasmapheresis, suppose you choose plasmapheresis. It is very, your IVIG is very costly, your child is 50 kg, you are not able to provide. Then plasmapheresis, what will you do?
25 to 50 ml per kg on the alternate days.
So totally 200 to 250 ml per kg, 5 to 7 sessions, alternate days.
But it should be considered in the...
What are the contraindications for plasmapheresis?
Extremes of age, less than infancy and autonomic disturbances and severe sepsis.
Very good. Sepsis, vascular instability, dysautonomia. In these children you cannot choose. So those are contraindicated. Apart from that you can choose plasmapheresis. Okay. Right. Then what will be the prognosis?
Ma'am, prognostic indicators are the maximum disability at the initial stage of
Number
presentation.
1, age. Suppose the child is an infant less than 1 year, then it is a poor prognosticating factor. Number 2,
maximum disability at the initial
acute
presentation.
apoplectic, very acute onset. Child is coming, walking in, and within 2 hours child is becoming paralyzed, respiratory paralysis, you are intubating.
Recovering ventilator
Dependency.
Axonal type in nerve conduction study.
Nerve conduction studies la axonal type rather than a demyelinating type. Finish பண்ணிடுவேன்.
Then bulbar palsy.
Next one is your autonomic involvement. So these are the poor prognosticating factors. Okay. What would be the prognosis? Mother is asking whether my child will walk or not, totally recover or not. What will you say?
80% of the child will.
Poor prognostic factors now we have told you. Then
80% of this child will.
70 to 80% of the children will recover. 100% they will recover. But recovery will take weeks to months. You have to say. They cannot expect the child to run over within say few days. You have to inform them weeks to months. Till then they have to continue the physiotherapy. Next. In the remaining 15 to 20% of the individuals, there will be residual disability. Then 3 to 5% of the individual, they will die. Okay. That percentage should come down because of our improvement in our management. Of course, autonomic involvement is a poor prognosticating factor that can kill a child. Okay. So which one? Last question. Which one is the first to last and last to appear in a child with
tendon reflexes?
Very good. So you have to monitor the child. You have to ask the mother to bring the child once in 15 days or once in a month, and you have to follow up the child till the reflexes reappear. You have to ask them to come for follow up. Okay. Fine. Anything? Any other question you want to answer? Thank you, sir. Thank you.
Thank you, ma'am.
Thank you. Bye. Good.